Well, good afternoon, everyone. My name is Patrick Stone. I'm the Director of State Government Relations for the National Psoriasis Foundation. Thank you for joining us today. Our purpose today is to have a robust discussion regarding the patient protections in Indiana, which have recently been codified into law following the passage of Senate Bill 41. I'd like to take this opportunity first and foremost to thank the bill sponsors, State Senator Michael Kreider and State Representative Martin Carbaugh, and the coalition of so many patient and provider groups that got this effort across the finish line. Truly, we would not have done it without all of your help. Should you have any questions for us, and I hope you do, please submit your questions in the chat section. This webinar is being recorded today and will be distributed to all of you, and feel free to distribute it to others within your network. Our panelists today, first and foremost, is Dr. Carrie Davis. Dr. Davis currently practices dermatology at the Dermatology Center of Southern Indiana. She is also a clinical assistant professor for Indiana University School of Medicine, Bloomington, and is the president of the Indiana Academy of Dermatology. Dr. Davis supported this legislation, and we thank her for her contributions to our efforts to get it passed. Her only disclosure is that she has received an honorarium from Celgene in the past. Michelle Guadalupe is the State Director of Advocacy and Access for the Arthritis Foundation, where she's responsible for grassroots advocacy and state public policy initiatives in the Midwest. In 2016, Michelle played a key role in co-leading coalitions to pass step therapy legislation in Illinois, Indiana, and Missouri. Both Michelle and myself have no disclosures at this point. Next slide, please. So we are offering CME credits for this webinar. The National Psoriasis Foundation is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. There is a 0.5 AMA credit being offered for this webinar. So I think it'd be helpful if we start off by giving kind of an overview of what step therapy is. Step therapy is when an insurer requires a patient to first try and fail on as many as 2 or more medications not originally prescribed by them by their healthcare provider before receiving the originally prescribed medication. And of course, the use of step therapy has been increasing steadily. In 2010, nearly 60% of commercial insurers were using step therapy, and as of 2013, 75% of large employers reported offering employees plans that utilize step therapy. These numbers continue to tick up and up and up. Insurers claim that step therapy helps to lower healthcare costs while maintaining or possibly improving care quality, and in some cases that's the truth, and in others it has the opposite effect. And I think it's important to mention that step therapy is not always utilized for a less expensive drug. Oftentimes, the drug that is originally prescribed is less expensive than the drug that the insurers are requiring the patient to step through. So let's talk about how step therapy can lead to increased costs. This is one of my favorite studies. A study comparing spending on schizophrenia medications in Georgia's Medicaid program. Step therapy saved the state $19.62 per member per month in antipsychotic expenditures. However, and this speaks to the siloed costs that we hear about quite often, these savings were accompanied by a $31.59 per member per month increase in expenditures for outpatient services. Reading in between the lines here, the state saved money up front, but the patients kept on going back to their doctor because the medications were not working for them. And I think one of the most trying statistics, or one of the telling statistics, is California, where an independent medical review of a benefit decision can be conducted in conjunction with the state and the insurance company. This is prevalent across the country, of course. In a study of their data over the past decade, 64% of all decisions made by an insurance company were reversed by the independent organization. Only 28% of the insurance company decisions were upheld. I think we all agree that number is way too high and creates a clear pathway for why this legislation is so necessary. And next slide, please. So with that, I'm going to hand it over to Michelle Guadalupe, who's going to walk us through Public Law 19 and explain a little bit about the bill. And then we're going to hear from Dr. Davis, who's going to offer some real-world situations where this appeal process is being used. Michelle, go ahead.
Great, thank you. And thanks to the National Psoriasis Foundation for putting on today's webinar. It has been a fantastic experience working with so many of our groups in Indiana, both our national partners as well as many of our local patient and provider groups. Some of those different local provider groups include the Indiana State Medical Association and also the Indiana State Nurses Association. It was having them engage with their healthcare providers and also our patient groups on why we were so successful. Just a little bit about Public Law 19/2016. I wanted to go through some of the main components of the law, and as Patrick mentioned, then have Dr. Davis go through how this really translates into the real-world scenario. Transparency and timelines. We all know how sometimes incredibly confusing working with health insurance can be, and when you are wanting to make, request a protocol exception, we wanted to make sure that it would be as transparent as possible, and that this information would be published on their website on how exactly to go about doing this protocol exception. We also really are aware of timelines, especially in emergency situations. We would want a response with 1 business day for those urgent care situations, and then 3 business days for those non-urgent care situations. We have heard that sometimes it can take days, weeks to get a response on one of these exceptions. And we know that is not ideal and doesn't work for patient care. One thing that we also heard loud and clear was you would be getting information back, but it wouldn't tell you the reason for that denial. And we know that can just add to the frustration and add to the delay in care for our patients. So if there is a reason for denial, they have to provide us a reason, and then also that clinical rationale. Also, these protections with formulary changes. We know that there can be changes that happen. We do not want patients to go without care. So having that written notification of at least 60 days before the removal or change is effective is crucial. We also want to make sure that if there is a removal off the formulary, that the patients would still have access to medication, so there isn't a time that they would be without their medication. The real crux of this bill, too, is overrides with our healthcare providers. There are 4 within Public Law 19/2016. So I wanted to go through each of these, and then I know Dr. Davis will be having some specific examples. So the first one on the screen, the required prescription drug is contraindicated or will likely cause an adverse reaction or physical or mental harm to the patient. I know our providers, have seen when this would be on a prescription medication, so we thought this was an excellent override. Second, the required prescription drug is expected to be ineffective based on both of the following: known clinical characteristics of the patient, known characteristics of the required prescription drug as found in sound clinical evidence. We know our oncologists, when they look at specific guidelines, they know which types of prescription drugs should be prescribed to their patient. Our third one is, and we've seen this quite often, if the patient has previously tried the required prescription drug or another prescription drug in the same pharmacologic class, or has the same mechanism of action and the prescription drug was discontinued. So we know, there's absolutely no sense in making a patient try that same prescription drug again, or in the medical opinion of the healthcare provider, if they know that it would have the same type of response, that same pharmacological class, that there should be an override granted. The fourth one, based on clinical appropriateness, the required prescription drug is not in the best interest of the patient, whether it could cause a significant barrier to the patient's adherence, could worsen a comorbid condition, or decrease the patient's ability to achieve or maintain reasonable functional ability. So for this one, we had several examples that I just wanted to go through. One of it being, you have a diabetic patient. and the prescription drug that they are required to take could cause weight gain. That is not in the best interest of that patient because of those clinical barriers. A second one would be you have a truck driver, and the required drug that they're expected to take is going to cause drowsiness. Now, would you want to be on the interstate with a truck driver who has taken a medication that is going to cause him drowsiness? I don't think so. This was just a really quick snapshot of the different components of Public Law 19/2016. I did want to point out a couple additional ones. This law is, it does apply to all prescribing healthcare providers and not just physicians. This impacts state-regulated health plans, so all state employee plans and fully insured plans. And we say if you are a healthcare provider and you're not sure, you can contact the insurer, provide the patient's policy number to determine whether or not they would, that this would apply, this law would apply to them. Thank you.
Well, thank you very much, Michelle. We're all really excited about these patient protections and the opportunities they're going to offer our patient community at the Psoriasis Foundation, AF, and really all people both living with a chronic disease and that are really just using the healthcare system. And so to talk about that, I'll hand it over to Dr. Davis.
Thank you. Thank you for having me. So step therapy practices have changed significantly in the past few years. It used to be that a patient would have to try and fail a cheap generic drug before they were allowed to try a more expensive branded drug. But, in the past decade, we've had the invention of numerous new branded drugs, and so we see these step therapy practices getting more complex. In some cases, step therapy can unnecessarily prolong ineffective treatment and prevent patients from immediately starting or even continuing to access the most effective treatment for their disease as recommended by their physician. Step therapy can lead to adverse outcomes for patients if the duration and the effectiveness of that required step therapy isn't properly managed. And delays in optimal treatment can actually add costs to the healthcare system with return visits to office, this is something Patrick said, visits to the hospital, hospitalizations, and even disease progression for our patients. This can also prolong their pain and suffering. And this is why protections like these are so important. Physicians and other providers, we know what's in the best interest of our patients, and we shouldn't be required to fail a medication that we find to be unsafe, ineffective, or inappropriate for our patients. And now with Indiana Public Law 19, we don't have to. I will provide a few examples of how this has worked for me as a dermatologist. I have a patient with, actually two, with a very similar scenario, patients who have chronic plaque type psoriasis who live in my town but work out of town on a very erratic schedule. Those patients would normally be required to step through therapy that would require refrigeration of a medication and frequent injections of a medication that they're not going to be able to be compliant with. So under the law, since I don't believe my patient could be compliant with care of one of these medicines, I think a longer acting, less frequent medication is more appropriate for them, and that's where I've been successful in that particular example. Another example I can give you is I have a patient with, again, psoriasis who was extremely fearful of systemic medicines and had severe psoriasis, something that wasn't controlled with topical therapy or some natural sunlight. Well, this patient, she was so fearful of any systemic medication that required lab monitoring that she wouldn't do them. Well, an option came along that was didn't have major side effects, didn't require lab monitoring, that she was more comfortable with. I was able to argue the fact that requiring to step through therapy would cause her actual mental harm, and I truly believe it would have, and was successful in getting her that alternative medicine and not being required to step through. And then again, I think you brought this up before, but if a patient has failed one class of a medicine and insurance is requiring them to try the other medication within the same class, we're going to assume most likely the patient probably will not respond to that one either. So it's another example of how you can use that law. Back to you, Patrick.
Thanks a lot. Thank you, Dr. Davis. Can we advance to the final slide, please, Amy? So one of the things I really wanted to touch on was the process that is in place for appealing these decisions beyond the internal process. And I don't see the slide that has a link, but we'll make sure to include it in the final report. But if you go through this internal exception process with your insurance company, and you receive a negative outcome, and you and your doctor believe that that negative outcome is unwarranted, your insurance company must provide you with an external IRO, independent review organization process, in order to pursue this further. If that does not come through in your favor, and you still believe that you are in the right, you have the ability to claim or file a complaint with the Department of Insurance. This process is very easy and explainable on the Department of Insurance website, and we'll provide a link to that website. So I'm looking for any questions from the chat section, and one of the questions I do see is where this legislation will be in the states in 2017 and where else the bill has passed. So the bill has passed in 4 states. Limited protections have passed in Kansas, and that's included in that comment. But in 2017, we're going to see this bill in a lot of states. We're very excited about the fact that it's resonated with legislators, that they really have gotten behind this bill as a means to address healthcare access issues. There will be bills in a number of states, including Texas and Iowa. I would encourage those of you out there that are in the government relations field to reach out to myself or Michelle about joining those local coalitions and contributing further to our legislative efforts. Michelle, I'll open it to you to provide any comments that you have on the future of this legislation.
Sure. Yes, this legislation will be in quite a few states in 2017, and it's been fantastic to be able to work with such a wide array of partners at both the national and also the local level. We've been able to, really kind of brainstorm and collaborate on a really very strong model legislation, which is what you have seen in many of our states and where we were successful with Illinois, Indiana, and Missouri this past year. So we will be building on those successes, and that's where we'll be going in 2017. So if you haven't been part of that conversation, and certainly definitely give Patrick or myself an email. We would love to get you and your organization more involved. We've really found having those local partners have been exceptionally helpful, and they've also been helpful to us in really understanding the landscape of a particular state and having a lot of those different connections with legislators, because as Patrick mentioned, it does resonate with our legislators, and many of them have actually experienced some type of step therapy. We've had some of our bill sponsors go through this in their own family. We've had our bill sponsors help strengthen our model legislation based on some of their life experiences. So, if you are a patient on the line, a patient organization, provider, we do have many one-pagers that we could share with you, because we know sometimes when you are at the doctor's office or if a patient's going to be going to a provider office, we just want to make sure that they are aware that this law has been enacted in Indiana and that they can get their medication that was originally prescribed by their provider.
Patrick, if you don't mind, I'd like to chime in. The step therapy laws are one of the top advocacy issues for the American Academy of Dermatology right now. So the AAD is working closely with many state organizations to push step therapy through for other states, and they were vitally important in our efforts in Indiana as well. Another thing I want to add as far as how to use the law when you need it, you can use it, because I didn't specifically touch on that. You can use it when you put in your initial prior authorization on a patient if you believe you think step therapy is going to be required of you, and you want to go ahead and put it up front that you don't think whatever step therapy you predict you will be faced with is inappropriate for that patient. Or if you're not expecting a step therapy and you actually get denied and you're appealing it, then you can reference the law on your appeal. And so you can direct insurance companies to Public Law 19, and I recommend that you make a printout of these slides and the reason behind why you believe that Public Law 19 would apply to your patient, and actually reference that in your original prior authorization or in your appeal. Some providers in this state do have some stickers that we can also affix to our appeals as well. So if you happen to have those, by all means, use them.
Thank you, Dr. Davis. So, what I'm hearing from you is there are multiple ways to utilize this law for an appeal. You can preempt. You can make an assumption that you're going to be denied. You know the step edit's going to be applied, and you can note so and cite the law, whether it be through a sticker or through a letter citing the law on the prior auth, or you can follow up by citing the law or using a sticker. There's multiple ways, and I like that suggestion. I think that printing out these slides, and for the providers that are on the webinar or viewing this in the future, printing them out and handing them to the person that in your office that handles the internal appeals and the external appeals. Feel free also, if you're a provider that's looking to utilize this, if you have a staff member in your office that wants to learn more about this, has further questions, reach out to one of us here on the webinar. We'd be happy to walk your staff through how to do so. I'm checking the chat here for any further questions as we wrap up. So how does a healthcare provider, this is a question from the chat, how does a healthcare provider, when they know the law applies and need an override, request an override to the health plan? Dr. Davis, do you want to, I think you touched on that a little bit, but do you want to get into a little more detail there?
Yeah, so I would say this would come in your appeal. So it depends on how you do your appeal. So if you get that original denial on your prior authorization, usually you get a ridiculously long form that tells you how to appeal that. So if you appeal in writing, I would actually write down and reference Public Law 19 and the reason specifically behind why you believe it applies in your case. If you're calling, again, I would reference the law that way as well.
Great. And there's a question from I think it's going to be a patient, thank you for logging on, that says, is this complaint the only route to get resolution? I have a denial in Indiana that applies to this law, and the insurance still declined the medication. So I touched on that earlier, and we're going to provide the links to the Department of Insurance. But if you Google Indiana Department of Insurance and complaint, you can file a complaint through that. Additionally, if you take a look at the denial that you got, so I'm assuming you filed an internal exception, and they denied it and they gave you something in writing. In that letter will be the process for the external review process. You still are afforded that protection. So you can go through that external process and then go to the Department of Insurance and file a complaint. You really have three different areas that you can act on to protect yourself. So I'm sorry to hear that the law has not assisted you thus far, but you still have further things you can do. And make sure to cite the law in your IRO appeal. I think that's really important. And copy and paste, take a look at this list, right, that we have on these slides. And if you see the thing that applies for you, say worsen a comorbid condition, all right, or decrease a patient's ability to achieve or maintain functional ability in performing daily activities, which that means is it's going to impact your work, right? Cite that, cite the law itself, and I hope that you will have a better outcome next time around. Let me.
And in hearing from the Department of Insurance, when we've talked to them about this issue, they really want, if you have tried, going through the health insurance plan first, and you're getting that denial, that's what they want you to do, of course, first. But if you're still having issues, Patrick had referenced the complaint line. What we've heard from them is, unless they have the complaints within that complaint form, that's really how they're able to address those issues. We can call and we can tell them that we're hearing from our patients, but they'll keep on telling us, we need to have it documented, we need to have them go through that form. This is then what we can do. We have to take that information before we can really go to the health plans.
Patrick, one thing I want to add too is to make sure everybody understands that this law does not apply to Medicare, Medicaid, VA, or patients who have certain non-fully insured employer plans. So before you even know you can use the law, you have to make sure it applies.
Thank you, Dr. Davis. That is part of one of the last questions that we have and that we'll wrap up with, and that is who the law applies to. So obviously, as you just outlined, Anything that the state covers to the extent that you outlined, but not Medicare and not Medicaid, is covered. But there's a specific question about rehabilitation needs, physical therapy, occupational therapy, speech therapy, etc. If step therapy is being utilized in an area that is mentioned in that question, this law does apply. If they're using the utilization tool, this law applies. This law does not carve out certain things like mental health, etc. The law applies to those things. Let me make sure we just don't have any final questions I think we haven't covered. I have a question here that says, has the Psoriasis Foundation or other groups done a template letter for prescribers to customize for that patient? We haven't done a template letter, and I think that's a fantastic idea, and maybe that's something that Michelle and I will speak with afterwards. And maybe that's something that Dr. Davis can touch on. Do you have a standard letter that you use in your office for each exception request, or do you customize that letter each time?
I personally customize mine each time based on that individual patient, what they've tried before, and then why I think they shouldn't have to step through therapy. So I customize mine.
Okay.
I think you could very well make a template letter, but I mean, you're still going to have to fill in the blanks with specific information about your particular patient and the reason why you're requesting that particular medicine.
Okay. Well, listen, I want to thank everyone for logging on today. I want to thank our presenters, Michelle Guadalupe from the Arthritis Foundation, Dr. Carrie Davis, and really everyone that participated in making this legislative effort a success. As you can tell, we have some feelings about the follow-through here. That's why we did this webinar. We want to hear from you. If you're having trouble in your practice or as a patient utilizing this law and you feel like your patient rights are being violated, please reach out to us and let us know. Let us know you're filing a complaint, and we will assist you in doing so. Again, this will conclude the webinar. Thank you, everyone, for participating today.
Thank you. Thank you.